So if a patient comes to us with, I'll skip the first few slides. If the patient first comes to us with a lid laceration, it's important that we don't directly jump to repairing the laceration. It's first is that we assess the systemic status of the patient, and second is the ophthalmic status. So in systemic status, we stabilize the patient. We take care of the ABCs of emergency care, the neurological status, and if cervical spine injuries are there, you accordingly ask for any imaging. Secondly, we look at the ophthalmic part of it. It's important, our first and foremost aim of rehabilitating a patient is preservation of vision rather than cosmesis. So the most important is we have to rule out globe ruptures and occult globe injuries. So once all of this has been ruled out, now we can focus on the lid laceration. So a brief history regarding the kind of trauma can give us some clues regarding the type of injury we can expect during surgery. So sharp traumas are usually associated with levator muscle or optic nerve injuries. Blunt traumas are associated with orbital fractures or canthal avulsions, and bite and claw injuries are very notoriously associated with canalicular lacerations. It's also important to examine the number of lacerations, the extent and depth, if the margin is involved, is the canaliculus involved. We'll look at each of these in the next few slides. So after all this, what is our goal of surgical repair? First and most important, preservation of preserve the eye and vision. Secondly, maintain the function. And third is restore the cosmesis. So all of this can be achieved by a well-executed primary repair. So some few principles of eyelid repair is, first, the repair should be done in layers, deep tissues first and superficial layers next. Secondly, identify the landmarks which help us to reapproximate. Like in this picture we can see these acute apices, angulations and brow hair. They serve as important landmarks for suturing the laceration. And if the orbital septum is damaged in the trauma, it's important that we don't repair that because that can result in post-op retraction and lag ophthalmos. So in superficial lid laceration repair, it's as simple as it can get. So we basically suture it with 2 to 3 mm distance between the two sutures. The most important principle that we need to ensure in this is to avoid wound tension. So if by chance if the wound is not apposing well, it's important that we undermine the skin and allow good apposition of the laceration. Now, what about eyelid margin repair? Eyelid margin lacerations are characteristically repaired in the form of a vertical mattress suture. So this vertical mattress suture is in a characteristic far near fashion. So what is the meaning of that? We pass the first bite about 3 mm from the laceration margin to exit 3 mm on the other side. And the same part is reversed and exited at around 1.5 mm on either side. So, and the deeper parts of the laceration can be repaired with direct suturing. These direct sutures we have to ensure do not go full thickness through the lid, otherwise they can rub over the cornea. These vertical mattress sutures are passed at 3 points, A, B and C, which is the anterior lid margin, the grey line and the posterior lid margin. So it's important if a patient presents to us with a margin involving laceration, we debride the wound in the form of a pentagon as shown previously, because this is the outcome when we suture that. However, if we suture the margin in the form of a V, it results in the formation of a lower lid notch, and that is functionally as well as cosmetically undesirable. So some lacerations may appear to be quite small on the anterior lamella, but they have a very deep component on the posterior lamella. So it's very important that you evert the lid always. Now what are complex lacerations? They are those which are associated with tissue loss. So whenever there's tissue loss, direct closure becomes difficult. So in such cases, to avoid any wound tension and eventual wound dehiscence, it's important that we relax the lid. Now, like in this patient now, there is a large upper lid defect, which is not amenable to direct closure. So in such a patient, there is a superior cantholysis done, which is cutting the crura of the lateral canthal tendon. This causes horizontal relaxation of the lid, which is now easily slid medially to close the defect. Larger defects can also be closed by Tenzel's flap. Now what about canthal injuries? We know the medial and lateral canthal angles are acute, and this is important to prevent epiphora. So whenever the canthus is involved in any laceration, it's important that we repair that too. So before repairing the canthus, it's important that we intubate the canaliculus and stabilize the fractures. And the most important principle to follow in these canthal injuries is to maintain a superior and posterior pull to the lid. What about canalicular lacerations? They are very characteristically associated with dog bites. And it's important that we repair it within the first 48 to 72 hours, because as the time passes and the tissue edema increases, it becomes difficult to identify the cut ends of the canaliculus. Once the cut ends are identified, it's important that we place a stent. Like in this picture, we can see a stent has been passed through the puncta, through the proximal cut end of the canaliculus, through the distal cut end, and then till the hard stop is felt. And the rest of the lid is sutured by the principles that we've discussed in margin laceration repair. So this patient presented to us in an emergency with margin involving laceration. This is a close-up photo which shows that the canaliculus is involved. So the probe was passed intraoperatively, which shows the puncta and the proximal cut end. And this is the result at the end, showing a well-placed mini monoca stent and a sutured laceration. This is another patient which has a bicanalicular laceration, and this is the outcome on day 5, day 7, and day 10. A brief about coloboma repair. We won't go much into the depths of it because that involves a lot of reconstruction. Just remember that one, we have to do a complete physical examination in these patients to rule out syndromic associations like Fraser's and Golden Heart. And second, look at the amount of corneal exposure that occurs because of a coloboma. If it's too much and there is exposure keratopathy, it's important that we surgically intervene immediately. So this is one patient who had bilateral upper lid colobomas. So how did we repair this defect? In the left eye, we basically did a superior cantholysis and slit the lid medially. This resulted in closure of the coloboma in the left eye. However, in the right eye, the defect was quite large, and this was not enough. In addition to a cantholysis, we basically took a rotational tarsal graft from the lateral portion of the lid. And this was the outcome at the end of 1 month, where the lid appears to be formed on both sides. This is another patient who had acquired lower lid coloboma following excision for a malignancy, and this was repaired using a Hughes tarsoconjunctival flap. This is another patient who had an upper lid coloboma following excision of a malignancy, who was repaired using a Cutler beard, which is a full thickness flap that we take from the lower lid and suture to the upper lid. This is the outcome at the end of 6 weeks. So the take-home message is it's important that we do a thorough examination in the presence of a laceration, not just ocular but also systemic. Secondly, rule out any embedded foreign bodies, which also need to be taken care of. Third, avoid wound tension. And fourth and most important, our main aim is preservation of vision, followed by function, followed by cosmesis. Thank you.
Thank you so much.